Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Joseph Eron. I'm a professor of medicine at the University of North Carolina at Chapel Hill, and welcome to Clinical Clips from IDWeek 2024. It's day 1 of 2, so I'm going to just jump right in. The first study I want to talk about is a long-term follow-up of subcutaneous lenacapavir in people that were highly treatment experienced and had multi-drug resistance. This is a study we've seen several times in the past, and it's been published. But at this point, we're now seeing the 3-year results. These were highly treatment experienced people who were viremic, who were then, some were randomized or some were just started on lenacapavir plus an optimized background. So what we're looking at now in year 3 is to see how sustained this suppression is. So at the end of 2 years, there were 54 people left on the study, and the percentage of people suppressed was just around 80%. And what we see after another additional year is that 2 people dropped out, one because of patient choice, another because of a side effect. But the number of people suppressed remains high. There were no virologic failures over the second to third year and no resistance emergence. So a sustained effect of this long-acting therapy with a background of optimized therapy. And in addition, the CD4 cell count continues to climb. So this study shows that once someone becomes suppressed on long-acting lenacapavir and an optimized background, they tend to sustain suppression. Okay, next on the list, there's a lot of studies here on the combination of long-acting cabotegravir and rilpivirine, many of them coming from the real world. The first one that we saw today was from the Henry Ford Hospital in Detroit. This study looked at individuals who started on of cabotegravir rilpivirine and were followed for at least 48 weeks. And what was slightly different than what we saw in the studies is that 8% of people actually didn't complete therapy. Either they discontinued therapy or they had virologic failure. And in this particular study, most of the people, in fact, virtually all of them, were suppressed at the time of switch. There are a few that were just above 50 copies. A larger study that came from the University of San Diego, University of California, San Diego, looked at people who were at high risk of non-adherence. And they used a very clear definition of having viral loads above 200 in the past year while being prescribed therapy or being out of care for a prolonged period of time. Interestingly, about a little bit over 40% were viremic at the time of starting therapy. 11% were actually above 10,000 copies. What this group did that was different than I've seen in other scenarios is the physicians and pharmacists that were caring for the patient decided actually to, in some circumstances, add an extra drug just for the beginning of their therapy if they were viremic. So that's a little bit different than what we've seen in other settings. But the bottom line here is that most people stayed suppressed through 48 weeks. But again, the success rate was lower than what we've seen in the randomized studies that originally got cabotegravir and rilpivirine approved. About 18% didn't complete, which is actually similar to the Latitude study that was presented at CROI that, again, looked at this kind of high-risk population. And in this population, 9% or 5 people had virologic failure. What's interesting is that baseline viral load wasn't a predictor of virologic failure. Low CD4 cell count and then substance use, especially methamphetamine, was a predictor. So that's not surprising, but important. There was a presentation about using long-acting injectable cabotegravir/rilpivirine plus lenacapavir in people with HIV who had viremia. This came from Mississippi, very small cohort, 9 individuals. Most of them, 8 of the 9, had rilpivirine resistance. Actually, 1 of the 9 actually had integrase resistance, not rilpivirine resistance. And in this small study, all 9 individuals who received cabotegravir/rilpivirine plus lenacapavir, obviously all injectable, all long-acting, stayed suppressed. So we're gathering data about using these 2 long-acting therapies, 3 long-acting drugs, in combination in people who just haven't been successful in navigating their therapy. We did see a brief presentation on the implementation of long-acting cabotegravir as PrEP in the Atlanta VA healthcare system. The VA, of course, drugs are available in the VA system, but they have this really nice algorithm for people who are very high risk or people who had adherence challenges. Those were mostly men who had sex with men. They also used cabotegravir when in people whose creatinine clearance was less than 60, and preferentially if it was less than 30. And then in women, which was a much smaller number, could actually have a choice between TDF, FTC, and cabotegravir. Now, in a year's time in Atlanta, they were able to initiate therapy or to begin therapy in 72 people. So it's not a large number of people getting long-acting cabotegravir, and a smaller fraction, about just under 90% of those people actually sustained therapy. And there was no discussion of outcomes in terms of HIV infections. But this is going to be a model for the, hopefully, for the VA system. And then finally, we saw pharmacokinetic data on a new long-acting integrase inhibitor. So this is a drug that's still in development. What I've talked to you up to this point have been about approved drugs. So this is GS1720. It's been studied as single doses in healthy volunteers that without HIV infection, and also as a single dose in actually 2 doses 1 day apart in people with HIV, and that's been presented before. It is very active as 2 doses given one time over an 11-day period. But this is the first study that is showing us about multiple doses. This study is in healthy volunteers who are living without HIV. And what they showed very clearly is that 3 different doses of 1720 had excellent levels given once weekly for 6 weeks, and very, very few side effects, very, very few adverse effects, almost all grade 1. So that's good news. High levels, well above the protein adjusted IC95. And then at the end of the talk, the presenter actually disclosed that this long-acting integrase inhibitor is being partnered with a prodrug of lenacapavir and given once a week in phase 2 studies in people living with HIV, including people who are treatment naive. And you might add, well, why aren't they using once weekly lenacapavir? Because that's something that's being studied along with islatravir. And I think it has to do with pill size. I don't know for sure because I wasn't able to ask that question. But it's an exciting opportunity for another potential once weekly oral treatment for HIV. And as a foreshadowing of, we know in the late breakers on Saturday afternoon that we're going to see the 48-week data of lenacapavir, islatravir given once a week. So stay tuned for that. Thank you for joining us on day one. Please refer to the landing page for the slides and to claim your continuing education credit.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.